Hi everyone, my name's Jamie Van Allen, and today we're going to be covering a very important organ, the heart, and how you as a future nurse will be able to understand the basic anatomy, blood flow through the heart, and in return be able to understand the cardiac cycle and interpret EKG strips. In order to meet this goal, we will be covering these objectives: understanding and describing the anatomy of the heart, describing the flow of blood through the heart, explaining the steps in the cardiac cycle and the parts that make the cardiac cycle up, as well as interpreting some basic EKG strips. Your heart's a muscular organ. It's about the size of your fist and it acts as a pump. It's comprised of a number of different parts, but the main ones are the multi-layered pericardium, vessels, arteries, chambers, and valves. For the pericardium, it's a multi-layered sac and it encompasses the heart as well as the great vessels. There are a number of different functions for the pericardium, but the three main functions that we're going to focus on is that it connects the heart to the mediastinum part of your chest wall. It protects the heart against infection and then also provides lubrication during each contraction. The three layers of the pericardium include the epicardium, the myocardium, and the endocardium. The epicardium is the innermost layer of the pericardium, and it surrounds the heart and roots of the great vessels. The myocardium is the thick middle layer, and it's composed of cardiac muscle. And then finally, the endocardium, which is a thin, smooth membrane that lines the inside chamber of the heart and forms the surface of the valves. So your heart is actually divided into a right side and a left side, and this concept protects oxygen-rich blood from mixing with the oxygen-poor blood. So the oxygen-poor blood returns to the right atrium and ventricle after circulating through the body and pumps blood to the lungs through the pulmonary arteries. Key thing here is that the arteries always carry blood away from the heart and the vessels always carry blood back to the heart. So the lungs then refresh the blood with a new supply of oxygen, and then the oxygen-rich blood enters the left side of the heart through the pulmonary vessels, which is then pumped through the aorta to the body to supply the tissues with oxygen. Also, key to remember is that you have 4 different valves with your heart, and that keeps blood moving in the correct direction. You have the tricuspid and mitral valves, and these are known as the atrioventricular valves. They make up the first part of your heart sound when they close, and that's the lub. Then you have the semilunar valves, and these consist of the pulmonary and aortic valves, and they're the second part of the heart sound, or the dub. So as you can tell, each valve opens and closes once per heartbeat, about once per second. So keep in mind the average heart beats about 100,000 times a day and 35 million times a year. That's a lot going on there. So sometimes the blood flow through the heart, it can be a difficult concept. I actually struggled with it during nursing school and found a very helpful, it's kind of quirky video with a girl who took a popular song and then put it to the blood flow of the heart. Helped me out with a lot of my tests, so perhaps you guys want to take a look at this on YouTube and see if it can benefit you. So your heart has electrical wiring, and that's what keeps it beating. The electrical impulses actually begin in the atrium part of your heart, and it's at a place called the sinoatrial or SA node. So the electrical impulses travel through this pathway to the ventricle from the SA node and deliver the signal to pump. So the conduction system keeps your heart beating in a coordinated and normal rhythm is what we want to see, which in turn keeps the blood circulating. The beating heart actually does 2 things. It contracts, which is known as systole, and then it also relaxes, and that's diastole. So during systole, your ventricles contract, and they force blood into the vessels, which then go to your lungs and the body, depending on whether it's going out the pulmonary arteries or out the aorta. So it's kind of similar, if you want something to think of, as squeezing ketchup out of a bottle. The right ventricle then contracts a little bit before the left ventricle does, so nothing's contracting necessarily at the same time. As your ventriculars relax during diastole, they're filled with blood, and that's coming from the atrium or the upper chambers, and then the cycle starts all over again. So now that we've covered the inner part of the heart and understanding that, we are going to take a look at the cardiac activity measured outside of the body through electrocardiography. So that is actually a method of recording the heart's electrical activity. It displays tracing on a paper or a computer screen per se, and it's actually a special paper that has specific markings that we'll cover. There's 3 different kinds of electrode placements that you could have. Well, there's actually a number, but there's 3 main types. You have a 3-lead EKG, a 5-lead EKG, and then you have something that we call a 12-lead EKG, but it really only has 10 leads. So for the electrocardiogram, what you'll see is you're going to see a number of waves and what they call complexes or intervals. So there's different parts which indicate, and each one indicates a different event going on in your heart. You have the P wave, the Q wave, R, S, and T waves as well. And then you have PR interval, PR segment, the QRS complex, and then the ST segment, as well as the QT interval. So for this, you want to take a look first at the P wave. So the P wave is the first short upward movement on the EKG tracing, and basically what that does is it's indicating that the atria are contracting and pumping blood into the ventricles. You next have the QRS complex, and this actually represents ventricular depolarization or contraction. You can also take a look at what we said was the PR interval, and that indicates transit time of the electrical signal to travel from the sinus node into the ventricles into something called the AV node. And then finally you have the T wave, which is another upward motion, and that represents ventricular repolarization. So when we're looking at this, we have specific measurements, like I said, that we were going to be looking at. So you have something called the PR interval, which is right here from the beginning of the P to the R wave. And that measurement we want to look at is 0.12 to 0.20. Anything bigger than that, it's going to be a block or some kind of arrhythmia. Then you look at the QRS complex, and that is measured from 0.08 to 0.10 on the strip. And then a QT interval, which is 0.40 to 0.43. These measurements here that I'm giving you, they are guidelines. You may want to look at what your hospital what your hospital uses for their measurements, because each hospital could be slightly different. When you're discussing this measurement, what you're really looking at are boxes. You have little boxes, and then you also have big boxes. So the little boxes are maybe a lighter shade of red or black, depending on what color you're using. So the small boxes represent 0.04 seconds, and you can have 5 of those little boxes making up a big, probably darker, more highlighted box, and that is 0.20 for your measurements. So now that we know the measurements, we can take a look at how to read the rhythms. So your first rhythms that we're going to look at are sinus rhythms, and these rhythms are cardiac rhythm, where the depolarization of the cardiac muscle begins exactly where it's supposed to in the SA node. So it's characterized by correctly placed and measured P waves on the EKG. So for the first one, our sinus rhythm, this one, you have your P wave right here, and it starts from here to here. And if I had to guesstimate that, I would say that your PR interval is 0.16. And then your heartbeat, this is a 6-second lead. What you're going to do to count your heart rate is you're going to count the QRS complexes and multiply it by 10. So you have 1, 2, 3, 4, 5, 6, 7. So that heartbeat is 70 beats per minute. And for sinus rhythm, we want them to be between 60 and 70 beats per minute. Next, we have sinus bradycardia. Sinus bradycardia, your initial cardiac impulse is starting in the SA node exactly how it should. Your PR interval is perfect, it's 0.20 or less, but your heart rate is less than 60. And then you have sinus tachycardia. Your PR interval also is good, it's 0.20 or less. but your QRS complexes are greater. So you have a tachycardic or higher heart rate, and that is when your heart rate's greater than 100. So next we're going to look at atrial dysrhythmias. And basically these are arrhythmias that are originating in the atria of the heart. You have two kinds that we're going to look at right now. The first one is A flutter, and then the second one is atrial fibrillation. So in A flutter, you have an atrial contraction, and it's regular, but it's faster, so you can't see the P wave. The P wave seems to be missing. Key thing here is that your QRS complex here to here to here tends to be slightly regular. Then we want to take a look at AFib. So AFib, also known as atrial fibrillation, is another atrial dysrhythmia, like we said. It's caused by a rapid, uncoordinated twitching of the myocardium of the atria. So your atrium is up here and it's basically beating like this while your ventricle's still pumping nice. So this is where your waves are irregular. Sometimes they can be flat, sometimes they're kind of nice and curved. Some patients do not have symptoms, other patients do. Symptoms, if they do have them, can include palpitations, the racing heart rate. They actually feel the beats that they're so fast, shortness of breath, and then also dizziness. The way that we would treat this is a number of different ways. We can give them different kinds of medications to slow the heart rate down and hopefully get them back into their sinus rhythm. We can cardiovert them, which is delivering electrical shock to basically stop the heart and restart it into a normal rhythm. We could do something called an ablation, which is where we basically ablate that area of tissue that's erratic. And then we also need to make sure that we're anticoagulating these patients because they are at risk for developing blood clots since their heart's beating irregularly. Next, we're going to take a look at ventricular dysrhythmias. So these are dysrhythmias that, you guessed it, begin in the ventricles. They are premature ventricular contraction, also known as PVCs, ventricular tachycardia, known as VTAC, and then ventricular fibrillation, or VFib. So PVCs are actually a relatively common event where the heartbeat is initiated in the Purkinje fibers instead of the SA node in the atrium. So basically what's happening is that the ventricles contract prior to the atria being optimally being able to fill the ventricles with blood. Initially, you may have just one occasional PVC, and those patients usually are not really all that symptomatic. It doesn't really pose that much of a danger. However, if you have more frequent PVCs, they could actually feel the irregular heartbeat, very similar to AFib. They could develop shortness of breath, dyspnea, dizziness. They could be feeling the palpitations. They could actually be feeling the force of the heartbeat, and just generally feeling uncomfortable. Treatment for this are medications. If it's caused because there's an electrical imbalance, maybe with their potassium or their magnesium, we're going to replete that and take care of those electrolyte imbalances. We could do an ablation, or we could implant something called a defibrillator, which helps to maintain an appropriate heart rate. Or if it's something just as minor as lifestyle modifications, possibly diet and exercise might be able to help the PVCs. Next, we have ventricular tachycardia. So it is actually a regular heartbeat, but it's fast. And what happens is it's happening because there's improper electrical activity in the ventricles of the heart. Nice to know that if you have a few of the VTAC beats, it may not cause any issues. So short periods of it may leave you asymptomatic, but you might be a little lightheaded, maybe feel some palpitations or chest pain. If you do have longer extended periods, that's obviously incredibly concerning because it can turn into your next dysrhythmia, which is ventricular fibrillation. So ventricular fibrillation, or VFib for short, it's the most serious cardiac rhythm, and basically what's happening is that the ventricles are quivering. There's just no real solid contraction to get the blood out. Treatment for VFib is CPR because you're in cardiac arrest basically at that point. So the last set of arrhythmias that we're going to cover are atrioventricular blocks. And basically There's a number of different kinds, but the first one that we're going to cover is first degree atrioventricular block. And basically what's happening here is that you do have electrical signals. They're just slower in the atrium. So basically, it results in a longer PR interval. So instead of your PR interval being 0.20 or less, it's greater than 0.20. So here is a good one. You have your PR interval here, and as you can see, it is much longer than the 0.20. So a lot of times this doesn't cause any symptoms. You may see this in runners. So there's no treatment needed for it. So your next set of blocks is second degree blocks. So this is where the heart block actually has some blocking between electrical signals between the atrium and the ventricles. So it is slowed, and then occasionally the electrical signal does not get to the ventricle. So if the electrical signal is blocked before it reaches the ventricles, they won't contract to pump blood to the rest of the body. For second degree heart block, it's divided into two different kinds. You have Mobitz type 1 and Mobitz type 2. So the type 1 is known as Winkie-Bach. So for Winkie-Bach, the electrical signals are delayed more and more. So you will possibly start out with a very nice PR interval, but then your next complex, your PR interval is longer, and then the next one's longer until finally you no longer have your QRS. Your QRS drops. So sometimes people who have this Winkie-Bach, they may feel dizzy, maybe have some lightheadedness, shortness of breath. It's less serious, so there may or may not be treatment there. Then you have your Mobitz type 2. So this second degree heart block is actually more serious. We may want to even consider a pacemaker at some point. So basically what's happening here is some of the electrical signals don't reach the ventricles. So the pattern is a little bit less regular. So you have it where you'll have the atrium and the ventricles doing very well. And then here you have your P wave, so the atrium's contracting, but you are missing your QRS complex here. And then here you have your P wave, your QRS, again your P wave, your QRS. So here it looks good, but then all of a sudden out here you're missing your QRS complex. So individuals do tend to get this type 2 mixed up with complete heart block, which we're going to cover next. So for complete heart block, or also known as third degree, this is where the electrical signal, there's no electrical signals, that actually reach the ventricles. So when it occurs, there's areas in the ventricles that do create electrical signals to cause it to contract, but they're just not rhythmic. So it's just kind of like a natural backup system for the heart, but there's no coordination between the atrium and the ventricles. So complete heart block actually can result in sudden cardiac arrest and death. This heart block is often a medical emergency. You may see these patients being put on external pacers. You'll probably end up with a pacemaker as well. So to tell the difference here, you can look at this and you'll see a P wave here, and there's your QRS, your T wave. Here's a P, here's a P, here's a QRS. There is no real coordination between the P and the QRS there. But if we are to go back and look at second degree type 2, your P to P, that is consistent. And when you do have your PQRS, each time you have a P and a QRS together, they are always, your PR interval is very consistent. So that's the way to tell the both of them apart. This link right here is actually going to take you to a very helpful website to do some practice strips. Keep in mind that there are some strips on that practice website that we did not cover, so don't feel overwhelmed if you don't get it correct. But it's very helpful for everything that we have covered, and it does give you reasoning as to what is going on with the electrical activity. So I hope this lecture helped you, and good luck.